My guest today is Sheila P. Vakharia. Sheila is a Ph.D. and also has a master's degree in social work. She's a nationally recognized harm reduction expert with over 15 years of combined experience in addiction treatment, harm reduction, higher education, research, and drug policy reform. She currently works at the Drug Policy Alliance, a national advocacy organization fighting to end the war on drugs. She is also the author of the newly released book, The Harm Reduction Gap, helping individuals left behind by conventional drug prevention and abstinence-only addiction treatment. Welcome, Sheila, and congratulations on your book.
Thank you so much for having me.
I was wondering if we could start by hearing your story. What is your background? What motivated you to engagement with drug treatment and more specifically harm reduction and your work at the Drug Policy Alliance and ultimately your book, The Harm Reduction Gap?
So, I was always interested in becoming a therapist. I studied psychology in undergrad. I got my master's in social work, but I was never really clear on the population or the topics or issues that I was going to specialize in. And it was my second year internship at the local outpatient addiction treatment program that really sparked my interest in working with people who use drugs. And through working there for a short period of time, I really became passionate about working with people who use drugs, people who were from all walks of life, all racial and ethnic groups, all socioeconomic statuses, and also all ages. However, I struggled with the framework and the approach that we used in the course of treatment as the intake coordinator. I rarely saw clients actually make it to the aftercare groups, which I was also facilitating. And so much of how I was taught or this was explained to me was that this is just simply the nature of addiction. People cycle in and out of treatment, people can't maintain abstinence. And so sometimes they're not going to succeed at treatment. And so people would be lost to follow up, people would be discharged, and people would often get violated on probation or parole or face some other consequence that led them to leave treatment early. And it was through those experiences that I saw that while treatment is a valuable tool and strategy for helping people engaging in high risk substance use, there's still so much about how we provide treatment that's limited in terms of who it can impact and how much it can help. And that was really what sparked my interest in exploring alternatives to our current abstinence based treatment system.
Were you at that time, were you even aware that there was a phrase or more or less, not not to mention a movement, something called harm reduction?
I think I had probably learned about it in school, probably within the context of HIV prevention, but honestly, I didn't really recall too much. But all I knew was when I worked at the treatment facility that it was explained to me that it had to be we had to be strict about maintaining people in abstinence in order to keep them in care. However, I had learned about syringe exchange programs and methadone clinics that engaged with people perhaps towards slightly different types of goals. And that did spark my interest in exploring alternatives. And sure enough, when it was time for me to leave the treatment facility, I only applied to two types of programs, methadone clinics and syringe exchange programs. And that's actually how I ended up at a syringe exchange facility right afterwards. I was interested in trying to find a different setting and a different framework within which to serve clients, one that didn't necessarily impose treatment goals on them that weren't necessarily their own, but also that I wanted to see what it was like to collaborate on different kinds of service goals and also the ways that we could retain people in services if we didn't have such strict requirements over attendance or participation.
Um, what is for our audience who may not even be familiar with the term harm reduction, give us a quick overview before we go in any deeper. What is harm reduction?
Harm reduction is a series of strategies, tools, and interventions, but also a broader social movement in which we recognize that people engage in high risk practices, whether it's drug related or in terms of their sexual practices or in other practices. And the acknowledgement that abstaining from those behaviors may not be practical, feasible, or tangible for all people. And so it's an approach towards helping people who may continue to engage in high risk practices to explore reduced risk techniques or strategies to keep themselves and their community safer.
Could one practice harm reduction if they wanted to lose weight?
I believe so. I believe that a lot of how we look at diet culture, for instance, here in our society, is you got to cut out the cake, you got to cut out the carbs, you got to cut out the sugar, for instance. A lot of diets are often highly prescriptive about what are good foods and what are bad foods. And so, for instance, many people struggle on those kinds of extremely restrictive diets because they're still tempted and enjoy certain food groups that are now deemed bad foods or harmful foods. And so, harm reduction, for instance, for people who are trying to lose weight may look like reducing your consumption of perhaps that sweet treat that you like so much, or being mindful of balancing out maybe some of these richer, heavier foods by making sure that you're also enhancing it with vegetables and more nutritious foods as well. So, yes, you can use harm reduction when it comes to a variety of things. This idea that the only way to be safe or to be healthy is through complete abstinence is really challenged by harm reduction. We're willing to work with people where they're at. If cutting out cake or cutting out pastries or cutting out pizza isn't feasible, let's think about ways to renegotiate your relationship with those food groups to keep them in your life, but also counteract and balance them perhaps with foods that may help you meet your goals, your weight loss goals, for instance.
This may sound like a silly question. Are we, as we talk and hope to broadcast this and share with other people, are we practicing harm reduction?
I think that part of practicing harm reduction is meeting people where they're at. And oftentimes, when I have conversations like these and talk about the harm reduction philosophy, I'm meeting communities and populations and audiences where they're at. And many of us are in the mindset that is part of the dominant mindset towards high risk practices that people should cut out certain behaviors and not do things. And so I try to meet communities where they're at when they have that kind of mindset by acknowledging while that sort of framework and way of looking at things can be really helpful for some communities, I'm trying to help them look more broadly about how beyond those who can't constrain themselves to abstinence, how do we imagine a world where we could serve more people? And so absolutely, by meeting communities where they're at, not telling them that they're wrong in their beliefs that some people perhaps are going to be safer if they don't use certain substances or engage in certain practices. I try to help them explore how to look slightly beyond and broaden their perspective.
Which sounds to me like drug education,
Absolutely, that's such a big part of it.
which which you discuss in your book, obviously. What is it in drug education? And what are we afraid to talk about? I don't mean Bill and Sheila, but I mean as a society, what are we afraid to talk about? And what do we need to talk about with our policymakers?
Those are really good questions. I think when it comes to drug education, we typically think about prevention, drug prevention education when it comes to our youth and our young people. And one of the things that I think a lot of us are very afraid of is that our young people are vulnerable to making risky choices and being impulsive, but also being drawn to behaviors that they know too much about. Perhaps the fear that if we talk about drugs or we talk about sex, we talk about a variety of risky behaviors that adults engage in with young people, that somehow we are being permissive or providing them education so that they go ahead and go forth and do those things. And many of us are concerned that, young people are still developing, their brains are still developing, impulse control, decision making, foresight, planning, all of those kinds of skills are still being developed in young people. And so when it comes to drug education in this country, so much of our drug education is grounded in trying to build fear among young people in the hopes that if they are fearful of certain behaviors that they will not engage in certain behaviors. The limits of a fear based approach, however, is that as soon as a young person then receives information through a peer or through some other source or through their own experience that counteracts that fear, that maybe getting high on marijuana wasn't so scary. taking a pull off of that vape wasn't the end of the world. Having that drink didn't make the sky fall. Immediately, then our young people have nothing to fall back on in terms of education, training, resources, or skills on how to stay safe. So I argue that while fear based drug prevention has a big place in how we talk about drugs, at a certain point that will hit an expiration date. And it's up to us to think about what the follow up messages should be to keep our young people in our community safer.
Would you take a guess? Could you pinpoint that expiration date?
I think it varies for everyone, but at the very least, if you wait until you are 21 years old to have your first drink of alcohol, there you go. That's one example. If you wait until you're 18 years old and you can legally buy a pack of cigarettes, that is probably when a tobacco abstinence message has expired. If you have an injury and a doctor prescribes you an opioid for your pain and you have no tools or strategies on understanding opioids and how to stay safe, that is when that expires. If you get diagnosed with ADHD and you're prescribed a strong stimulant drug such as Vyvanse or Adderall, you are then also experiencing an expiration date to drug prevention messaging because you are not given the tools to stay safe.
I have had at different times, I've had people talk to me, or I've been in conversations where people are talking about a gateway drug. And my response is that a gateway drug, or my idea of a gateway drug, is adolescence, spelled CE at the end, but then adolescence also spelled with TS at the end, because I think adolescents, plural, influence the choices we make in adolescence, if that's sounds clear to you. And
Sure.
influence some of those, "Oh, 1 drink, 1 puff, 1 pill probably won't bother me," or influence people when they discover that the 1 drink, 1 puff, 1 pill actually didn't, as you say, the sky didn't fall down.
hmm I think what troubles me about the gateway drug theory is that it pins this idea that substances are like a domino effect, like trying one drug is the leads to a domino effect of trying others, and that that's somehow unique to young people, or that that's somehow the trajectory that everyone's going to find themselves on. And I would challenge people to think through the ways in which actually the environments that we find ourselves, the situations that we find ourselves in, and our mindsets and our emotional mindsets and expectations dictate the choices that we made. It's not just as simple as I tried marijuana once and now I'm going to go shoot heroin. That's not really how it works.
Yeah. What about peer-to-peer drug education? I had somebody, one of my most recent guests said, if you wanna reach adolescents, you wanna reach kids, they could talk to an adult or they could talk to an old fogey like me, but you really wanna get to 'em, have somebody their own age talk to them about who's had a problem with addiction or substance use disorder. Have somebody their own age reach them. Any thoughts on how we might do that, and or what are your suggestions for improving drug education?
Well, those are big questions. I do think that peer to peer education and resource development is super, super essential because young people know the risks that they're facing. They know the stresses and the challenges that they're facing, and they know the coping skills and strategies that are available to them. And so I think there is absolutely a value to young people talking to young people about staying safe and how to keep them one another safe. I also think that there's a time and a place for a health educator or an adult to have those conversations. And I think that parents can be those adults, neighbors can be those adults. I think when it comes to safety and drug prevention or harm reduction education, I think different people are going to need different messengers. And so I love the idea of more diverse messengers beyond, for instance, when I grew up, which I write about in my chapter 1 of the book, where the only messenger who I had the delivery of this message from was a law enforcement officer who came into my classroom in my DARE class. And so there's absolutely so much that can be done when young people can educate each other and stay safe and really speak to each other as peers and understand what they're going through because the new generation is going through things that a lot of us can't relate to. They're facing challenges and stressors and they're living in a society that's very different than the ones that we came up in. And so absolutely I think that's so important. Now, back to your second question about what is it that we can do to improve drug education or think through the possibilities of what drug education can look like. What I would say is that we really need to think about developmentally appropriate messages for young people. When we're talking to elementary school children and small children, the message should be, don't drink something that's in a glass that you don't know what's in there. Don't open that bottle under the kitchen sink and drink something out of it, even though it's a pretty color, right? Most of the calls for poison control that are among young people and in families are often because children consumed household products. And so we should be really mindful that young children are going to need initially messages about making sure that an adult gave this to you, that you know what you're allowed to eat in the house, that you don't eat something out anything out of any cupboard that you see. And just because something's a bright color doesn't mean you can consume it, right? My household cleaner is Fabuloso. It's a bright purple color. That is the color of some Kool-Aids, but I do not want a child drinking it. But we should probably be telling our kids not to be drinking things out of any cabinet that they see, for instance. And then as young people get older, really giving them education about what drugs are, why people use them, what the effects are, and why is it that some young people use them more often than others, and making sure that drug education is actually also about mental health and social skills building. One curriculum that I'm really excited about is the Safety First curriculum that we developed at the Drug Policy Alliance, the organization where I work, but it's now housed at the Stanford Reach Lab. And it's a curriculum that's focused on drug education that encourages young people to also build their literacy in health literacy, in researching and comparing and contrasting various sources of information about drugs, and being able to come up based on the information that they receive with a clearer idea of what drugs do and don't do in the body. But simultaneously, talking about mental health and stress and boredom and anxiety and all of these emotions that are often drivers for young people, but also people of any age to want to use substances. Because the habits and the coping strategies that we develop in our youth often carry over with us in adulthood. And so, really seeing that prevention of even more exacerbated mental health symptoms or potentially problematic drug use may be rooted in the need for young people to start developing coping strategies to deal with the stresses of their day to day lives, to be able to recognize that my symptoms are perhaps a mental health diagnosis for which there's other kinds of treatments, to recognize that like boredom is a really big problem for me. How do I cope with boredom as a young person? What are some things that I could be doing? And like, how can I develop those strategies now? Because those are the kinds of things that will help prepare them better for adulthood. And then the last thing that I think that drug education should really focus on is really helping young people understand how to keep one another safe. How do you recognize when someone's had too much to drink? How do you know what to do if a friend or a loved one, or even you come home and your parent has had too much to drink? Or how do you recognize when someone's had an overdose? What are the signs and symptoms? And when is it safe to call 911? When is it important to call 911 for help? And what are some other strategies that you can use to keep this person safe in the meantime?
Mm, two things about your response. One is, you when you were talking about the purple the purple liquid in the bottle. When I was a boy, a young kid, somehow out in the garage was weed killer with arsenic in it, and I
Mm.
sampled some. And I
Mm.
remember, as the story goes, my father, on a weekend, wound up trying to get on the telephone to contact the president of the company to find out that manufactured it, to find out what to do, where to take me.
Mhm.
And there were brown spots on the lawn where I had apparently I don't know. Could be
I'm so
said that
glad you made it. That sounds terrifying.
I'm here. Yeah, yeah. The other thing about education, my question is, I and gap is a good I think gap is a good word here. How do we educate, or how do we reach the adults that need to be talking to kids? How do we educate parents and teachers, and especially to have the both the knowledge and the understanding that they need to be able to talk wisely, if you will, to young people? Seems to me that there's a gap there that we need to fill. We have got a you just mentioned you've got a curriculum for kids, but I think we need to familiarize the adults with that curriculum.
I absolutely agree. So many adults lack information because they were never given any sort of drug education growing up, or they really managed to get away with somehow managing to stay safe all this time, but never really learning the mechanics of how drugs work together, the risk practices of mixing two classes of drugs or chasing a pill with a drink of alcohol or taking two substances very close together or increasing a dose without consulting with a doctor. I think absolutely the lack of knowledge or awareness around drugs is not just among young people. I'd say that our general society has grown up with a lot of mythology, misunderstandings, or just silence when it comes to substances. And so people could have learned skills, tools, strategies, and actual information to keep themselves and their loved ones safe. And unfortunately, missed those opportunities. There was nowhere to go. They didn't know where to look. No one was there to talk to them about it.
Yeah. As a former teacher myself, or still, I always like to think of myself as a teacher. Uh,
Mhm.
I I think about sort of the what I call the meta curriculum, the history, and this is stuff you talk about in your book, but the history of the drugs are connected to racism in our country. We need to be talking about that. We're talking to young people who are going to be the policymakers of our future. And do they have any connection or any awareness or understanding of what the policies that we have are, how they were arrived at, the insanity of what you will, of what has brought us to the policies that we have now, and our inability to change them because politicians are locked in creating nothing. Obs- They'd rather obstruct than construct, if you will.
Do you
Which leads.
feel Oh, sorry,
Go ahead.
go ahead. I was just gonna say that I actually feel like young people today are far more aware of the history of our drug laws than a lot of adults. I find that a lot of young people in now growing up in a world where marijuana is legal, more and more Americans have access to marijuana. I do feel like the more young people I talk to, the more they say, "We know that there's racial disparities in our criminal justice system. We know that communities of color are disproportionately targeted by the police, especially when we consider drug policies." And I do feel like young people, through pop culture and the kind of media they consume, I find are actually make me very hopeful about a world with more sane policy that's grounded in the reality of what we're facing. But it's often the adults who took as word that our laws were passed in a just way, that are often the ones who are most surprised by the history of our drug laws. But I find that the newer generations are much more critically minded about our histories. They're more likely to ask more questions and to challenge dominant narratives and to be open to alternative ways of thinking things. They make me very hopeful.
Oh, so let me take the adults, if not the kids. Can we visit the war on drugs for a while? As I read your book and I looked at some of the drugs drug laws that were passed, certainly the Harrison Act, I noticed that there's a relationship between drugs and how society feels about drugs and taxes. So the Boston Tea Party, tea was thrown overboard because we were being taxed for tea. Not much later than that, we had the Whiskey Rebellion because people in the Western United, what was then the Western frontier of the U.S., didn't want to have a tax on their whiskey. The Harrison Narcotics Act was called the Harrison Narcotics Tax Act. The 1937 Marijuana Tax Act. There's a relationship here between taxes and drugs.
That's a really interesting observation. Absolutely. And taxing became a pathway to prohibition. The logic was that if we start taxing, at least when it came to the Harrison Narcotics Act, cocaine and opium derived drugs, and then later for the Marijuana Tax Act for cannabis derived drugs, that they could control the market, see who was in the market, and restrict access for people who couldn't afford those taxes. And so in when it came to illicit drugs, it was not only a way to make revenue, but it actually was a way to get a hold on an industry and get a hold of who was consuming and perhaps create a bit of a financial barrier to restrict the purchasing of these substances.
Um, Financial barrier as opposed to
So making it a little
making,
bit more making it a
yeah.
little more expensive, right? So making it so that not everyone could afford access.
But then, I mean, certainly I think this is an issue with cannabis now. What do we do with the money that we make from the taxes from the sales on cannabis? How do we use that money? How does it get used for the common good? Which it seems to me is being figured out in any number of ways in different states and different places.
Yes. So it has been quite diverse what states have decided to do with that revenue money. Some of it goes right back into the regulatory structures, right? The ways in which we're already regulating the industry. But then, absolutely, in some states, it's been part of a pool of money that's helped to pay for more drug prevention education in schools. In other parts of the country, for instance, in Oregon, what they did was after they passed Measure 110 to decriminalize drugs, they said that cannabis tax revenue money could be used to build out an entire treatment infrastructure that expanded access to harm reduction, recovery, housing, and treatment, for instance. In other communities, such as here in New York State, where we both live, some of that money has been earmarked to then become grants to go back into communities most policed to help build out programs to help enhance communities, after school programs, community development, education, all those kinds of things. And then, sure, in other places, it's gone into a black box where we have no idea where that money is going. Is it being used to offset budgetary shortfalls? Is it used to fund other types of things? Is it used for policing and enforcement? Those kind of diverse outcomes are quite a range from state to state.
You mention, I'm familiar with it, but you mentioned the iron law of prohibition in your book.
Mhm.
Can you explain that? Because I think it has a lot to do, certainly, with the rise of fentanyl now.
Right. So, two really fantastic thinkers in our space, Corey Davis and Leo Beletsky, wrote a really fantastic paper several years ago about how the emergence of fentanyl is the modern day example of the iron law of prohibition at work. And the examples that they start with is the original example that they propose of the iron law of prohibition was around alcohol prohibition about a century ago, when Americans largely drank ale and wine and low potency alcohol beverages before prohibition was passed. And when alcohol was banned for that 13-year period, people still had a desire to drink alcohol, and so they fueled an underground market for alcohol to still be provided in our communities. And what many of these people who were transporting and distributing and selling alcohol on the underground market learned was that it was far more challenging to go from neighborhood to neighborhood to carry drug alcohol across state lines when you think about how many barrels of beer you would need to carry or how many barrels of wine you would have to carry. It's not very discreet to transport those low potency, high volume alcoholic beverages. But on the other hand, something like moonshine, which is a bathtub developed fermented like stronger liquor, can be trap can be carried and brought around far more discreetly because a little bit goes a long way, and so you could more discreetly carry a jug or a handle of one of those kinds of liquors rather than wine or beer and not get detected by law enforcement. And so what we saw was that prohibition incentivized the development of a more potent, discreet, and smaller quantity of the same drug. And it was through prohibition that American drinking habits shifted. As I mentioned before, we weren't really that interested in higher potency alcohols, but our cocktail culture, our mixology culture, the way that we think about speakeasies now and different kinds of bars that we like frequenting, a lot of that shift in our alcohol culture was driven by prohibition and a shift to a more potent alternative. And so, in using that same logic, Beletsky and Davis argue that when we at the turn of the early 2000s, started seeing prescription opioid related overdose deaths increasing and started restricting prescribing habits, seizing more pills, and doing more enforcement around pills. We then shifted people from getting their medicines and their drugs from prescribers in legitimate medical settings to the underground market, where heroin is a slightly more potent alternative, but it is far more cheaper and was more accessible to people at the time when they were getting weaned off of prescription opioids. And then when we started seeing heroin overdoses go up nationally around 2008, 9, 10, 11, and 12, the crackdowns on the heroin supply disrupted heroin supply chains that were now meeting demand of people who had shifted over from prescription opioids. And the supply couldn't keep up with the demand, and we were also restricting access to heroin. And so suppliers learned that we could synthetically make a higher potency fentanyl product rather than sitting around and waiting for an opium plant to grow enough so that we could make heroin from it, making it from these synthetics instead, and then cutting it into the drug supply to offset the fact that the heroin was of reducing quality, was low potency, and was more supply, the supply chain was more disrupted. And so the entry of fentanyl could be a parallel in a way to our experience with alcohol. And here we now are in parts of the country where we live, for instance, here in New York, where the heroin supply is virtually non-existent. It's hard to find pure heroin anymore. Fentanyl is now the street opioid that people are using, and it's led to a dramatic shift in our underground markets and drug use patterns.
Thank you for that. Um, because it's very, very clear. I've understood this law for quite some time, but it's interesting to me because it almost every drug has had its reduced form, its more potent form.
We are starting to see that. Yes. Yeah, I mean, in the Incas in Bolivia and Peru, the ancient people of that community were very drawn to the coca plant. They call her Mama Coca, and they say that the coca plant has such a significant role in their society and culture. And largely through chewing the leaves, they were able to work the fields, but also brewing it in teas could help them deal with altitude sickness. And they would make tinctures and tonics, and it would be part of their foods and candies and all of these different kinds of products. And when it's originally from the plant itself, it's a much more milder form. And yet, what happened was at the turn of the 20th century, we saw scientists extract the most potent compounds from the coca leaf to synthesize what is now known as cocaine. And cocaine is the most commonly used coca derived product here in the United States and in much of Europe. However, it was a plant and it is a plant that has so many more values and purposes and functions in its most lowest potency form, comparable to caffeine or other mild stimulants. Yet, prohibition and the markets that we're engaged in have incentivized also our relationship with this plant to only really understand the most potent form of it.
Um, when we talked about, sorry for the pause here, the iron law of prohibition. Prohibition was passed by politicians. Politicians or ruling authorities have always, you can name any drug, tea, coffee, tobacco, and depending on where the society is or who's in power or what happens to be going on at the time, people have been punished for just about every drug we can think of.
Absolutely. And we use our drug laws to scapegoat certain communities and use them as an excuse
Yes.
to target and enforce certain communities, because there are versions of these drugs that are always going to be available pharmaceutically. There are legal forms of many of these substances, but through our laws, we have stratified those who are deserving of safe, regulated access and those who are not. And those who are not are often on the brunt and the receiving end of enforcement that affects their freedom, their liberty, their ability to live with their families, their ability to work and be part of their communities, while other people have steady access to a safer supply of these substances without fear.
You and I'm going to read a small quote, if I may, from your book, because I've seen it in probably 3 or 4 other books about the drug war, and it's John Ehrlichman, who was an advisor to President Nixon, and it's about the drug war. Now, Ehrlichman said in an interview, he said, "We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night and day on the evening news. Did we know we were lying about the drugs? Of course we did." I don't think it's any accident that that quote appears in any number of books.
It's telling, it's revealing. I mean, what else is there to say? It's so clear that had public health and public safety been the overarching concern when we started seeing drug related harms increase at the turn of the 20th century? The turn of the 20th century, it was estimated that about 200,000 people in the United States had developed some sort of addiction to opiate medications that were freely available through Sears Roebuck and other pharmaceutical or pharmacies at the time. You could order a syringe full of an opiate and it could come to your home. And so, there wasn't any regulation, there wasn't any oversight. Americans had no idea what they were consuming or the risk factors. And when we saw addiction emerge, it would have been a great time. And we did start passing some laws, the Pure Food and Drug Act, for instance, where we said, if you're going to sell a substance, you need to label it for its compounds and you need to tell people what's in it. But going even further, we could have chosen then regulations that were common sense that expanded access to information about how to stay safe, that ensured that consumers were aware of what they were consuming and why, and that they were allowable in certain doses and those sorts of things. But we didn't choose that pathway from the beginning. Instead, we said certain forms of opiate use by certain people and certain routes were okay, and certain forms weren't. And then we used racialized imagery, xenophobic imagery, and messaging oftentimes in our media. And that was regurgitated to us by our politicians that instilled so much fear about these racialized others, fueled by these drugs, that led to the willingness for many to pass prohibition.
Which reminds me that as we discuss it, I believe today, even as we're talking, we have 2 American politicians who I shall remain unnamed, but they're important politicians who are visiting the Mexican border.
Hmm.
And those visits are in some ways veiled in terms of what we say or believe about what comes over the Mexican border and who the people are that bring it.
Absolutely. Absolutely.
What about rural areas? And for example, Sullivan County, where we are now, you're a New Yorker. You've spent a lot of your life in New York. And when I say that, not just New York City, but upstate New York,
Right.
correct?
Yes,
Okay.
yes. I grew up and my parents still live in Broome County. I went to college in Rochester and now I live in New York City in Kings County. But yes, outside of 3 years of my life, I have basically spent my entire life in New York State.
So, so how do we bring to or practice harm reduction in the vast parts of our nation which are vastly underserved, rural areas?
Yeah, it looks like a lot of things. It looks like a multi-pronged approach really to help expand access to people in rural communities because rural communities, when we talk about some of the challenges, one of them is transportation and being able to make it from one side of a county to another because people are really spread out and populations are not very dense, right? So, when it comes to expanding access to harm reduction, for instance, we have to use the tools that are available to us that make sense for people in more spread out areas. And one way to increase access is really important through web based and mail delivery systems because people in more rural communities do largely still use the internet to access information, to get resources, and to connect with their communities. And what's really excited me about harm reduction in recent years is our willingness to move online. There are so many harm reduction support groups that people can join online, whether they want to moderate their drinking, reevaluate their relationship with alcohol, or talk about harm reduction when it comes to other drugs. And so I think that particularly for rural communities and people in more remote places, the use of online support groups is so essential so that people can reduce isolation if they can't actually, they don't have a neighbor nearby, or they don't have a drop-in center, a place where they can go to make that community. I would also say mail delivery is another huge innovation. Next Distro is an incredible national harm reduction mail delivery organization that sends naloxone, the opioid overdose reversal antidote, to people's homes. They also help send syringes and safer smoking equipment in states where that's legal. And here in the in New York State, especially, OASAS helps support, and through the Office of Drug User Health, we have a variety of supports in place for that sort of thing. And I think mail delivery continues to be a really important touch point for people. And then lastly, thinking of innovative places where people can get their needs met in communities where they do want to go get something in person. And so pharmacy based syringe access, I think, is really important. And, the new piece of legislation that's being talked about federally, the MODA Act, which would allow potential pharmacy based methadone dispensing, which would be incredibly exciting, but also expanding access to methadone in treatment facilities, because many of us live in communities where there isn't a methadone clinic nearby. In Broome County, where I grew up, we have the only methadone county or methadone clinic for all the surrounding counties where we grew up, or where I grew up. And so people would have to commute in to Broome County to get their methadone. And so thinking about innovative ways to get methadone in pharmacies or in other treatment facilities, I think is really important. And then lastly, really integrating harm reduction into how we provide treatment. So if people are going to treatment facilities in person, that they're able to get that. And then thinking of the advantages of telehealth, people getting initiated on buprenorphine and maintained on this life-saving medication for opioid use disorder by over the phone or through video conferencing apps, I think is also a really huge strategy. And then last of all, I would like to shout out the Never Use Alone hotline, which I feel like has tremendous promise for people in rural communities. Many of you may be familiar with overdose prevention centers or supervised consumption sites where people can come to a location and use their pre obtained drugs on site. So if they overdose, someone's there to respond and to make sure that they're safe. The Never Use Alone hotline, you can live in any kind of community, rural, suburban, or urban, and call someone on this hotline. Say, I'm about to use a drug. This is my address. This is where I am. And if I don't respond to your prompts in 30 seconds, you have my permission to call an emergency, call the emergency hotline and have someone come and check on me. I think is a really important resource as well.
Wow. As I read your book, I was struck by, let's call them binaries or juxtapositions. I'm going to read a few. The title of the book is The Harm Reduction Gap, and I've thought of the harm reduction divide, harm reduction chasm. That's just me reacting. But we have a harm reduction. We have a two-tier system. So we have the divide binaries: urban, rural, white people, people of color, access to treatment, incarceration, good drugs, bad drugs. Drug, you call that drug exceptionalism.
Hmm.
Drug user, the drug abstinent. What is a drug? What isn't a drug? What's a drug? What's the pharmaceutical? Meth- Methamphetamine, Adderall. Criminals, patients, syringes, pipes, compassion, punishment. Who gets a regulated supply? Who doesn't? Grassroots, government, abstinence only, harm reduction, health issue, crime issue.
I love that. I love that you just pulled that out. I didn't even think about that.
Well, you got me thinking. You got me thinking. Do they make sense? Am I
So much of our world is about dichotomies, and it's about polarization, and it's about opposites. And we don't look at the world on a continuum. We don't look at drugs on a continuum. We don't look at our responses on a continuum. And so, whether I realized it or not, highlighted that and I named that in the book because I feel like in naming those, we can actually see that it's more about how do we keep people in the gray? How do we find that middle ground? How do we move a pathway forward?
Yeah. How do we go from, well, the harm reduction movement and certainly the work you're doing, I go back to compassion and punishment. How do we avoid punishment, or how do we use compassion to get to at least the gray area, to some place where people can practice harm reduction?
hmm I think part of the challenge is that we've dehumanized, marginalized, and stigmatized people for so long that so many of us, it's part of the oxygen that we breathe, the stigma, the judgment, the scorn, the shaming, the blaming, the guilt, that compassion is really challenging. When we've dehumanized a group, when we've belittled them on the nightly news, as Ehrlichman said, it's really easy to see certain people as the enemy. And Nixon said it himself, drugs were enemy number one. And it's not just the drugs, it's the people who use them. And it's not a war on drugs, it's a war on the people who use certain drugs. So I think the first step is humanization and understanding where people are coming from and seeing ourselves as people who use drugs, understanding that drugs are a lot of things. And just because your drug was legal and it was acquired through a prescription or you got it at a corner store and it has a nice label on it and you know what's in it, doesn't mean that your drug use is any more valid or safe or worthy than someone who may have to buy their substances on the underground market. And a statement like that is a controversial statement to make. But it's only when we break down these dichotomies and take out the good and bad drug and take out the good and bad user that the possibility of compassion opens up. But as long as we believe in these extremes, it's really hard to reach across and feel compassion for someone. It's so much easier to want to judge, scorn, punish, exclude instead.
Which which leads to my question, what about in your work, what about the naysayers or even people who have legitimate questions? What do you say to them? How do you counteract them? Because there are certainly people, well, just in San Francisco now, the mayor is saying, "This harm reduction isn't such a good idea." This is somebody who was pro harm reduction, and now she's come out and arguing against it. There seems to be people in Portland, Oregon that wanna change the laws that they've passed. Some of this, it seems to me, is that the notion to do something, to do good, is a good notion, but it isn't necessarily well thought out. We've passed the law, but how are we going to implement it, and how are we going to give it the time to see if there's any positive effect, and how can we measure if there will be any positive effect?
I think that harm reduction has been unfairly scapegoated for a lot of broader social and structural challenges that have really come to the fore in our current COVID and post COVID world. I think that COVID laid bare social and structural inequities, gentrification, housing inaffordability, lack of access to social services, people getting disconnected from their communities, and the desire to return back to business as usual without really going back and reinvesting and building up the systems that we needed to keep our community safe. And it's easy to point to someone on a corner who's struggling and suffering, who probably has multiple compounded needs, including housing, stable access to food and nutrition, other kinds of resources, mental health support, medical support for health issues, and support for their drug use. It's easy to point to the most explicit thing about them that dehumanizes them the first, which is their drug use, and then to pin all these broader social problems on drugs because we've done that. The scapegoating of drugs and people who use drugs has remained such an undercurrent in our country. When Reagan and when Nixon talked about crime, they were it was coded, but it was about drugs. And so again, today we are using language around scapegoating people who use drugs as a way to gloss over the fact that we've never really invested in housing. People in my generation, I'm an elder millennial, cannot afford to buy houses. We are getting priced out of our communities. Corporations are buying up homes. The single family house being affordable anymore is a pipe dream to many people in my generation and younger than me. And instead of really acknowledging all of these broader structural factors that are often influenced by corporate actors who want to build up their bottom line, making food at the grocery store more unaffordable, something called shrinkflation, which is you go to the grocery store and your box of cereal doesn't have as much cereal in as it used to, but it's more expensive
Yes.
than it was. Instead of really pointing at all of these things that are really affecting Americans today and our communities today, and wages not really rising on par with all of these other factors, it's so easy to say, well, they're all a bunch of drug users, and it's because we're not arresting them for drugs that we're seeing them out there, rather than saying, first and foremost, these are people who need housing. These are people who need mental health and medical and nutritional support. These are people who need help getting back on their feet again, or for the first time getting on their feet. And it's easy to point to their drug use or their imagined drug use as being the root of these issues than really taking responsibility for the deep, expensive investments that we actually need to make to bring all of our communities up to where they ought to be.
Which would bring me also back, not only, but certainly brings me back to rural America. We're nearing the end here. I just need to find, yeah, 2, well, one other question first. Who in your work with drugs and your work in your writing, who are some of your heroes? Who are the people that who should we be reading? Who should we be listening to?
Ah, so many people. So many people influenced my thought and
That's
my
who's
own evolution. I mean, some of the people that I'd love to shout out are Pat Denning and Jeannie Little, who have written extensively about harm reduction psychotherapy, because my inroad to harm reduction was actually through being a harm reduction therapist at a needle exchange or a syringe exchange program. Andrew Tatarsky, Alan Marlott, these are all thinkers in the harm reduction therapy space who were my first real touch points into this. I would also point out Norman Zinberg, whose drug setting model I talk about extensively in one of the chapters in my book, in thinking through alternatives
very, let
to.
me interrupt, a very important chapter, and it made setting as clear to me as anything I've read. Sorry to
Oh,
interrupt.
no, that's wonderful. Thank you so much. I'll take that as a compliment.
You
So
should.
his work really zooming outside of a disease model thinking of why certain people develop the kinds of relationships with substances that they do, and that we don't have to ascribe to a disease model, which always didn't sit right with me. And that brings up Stanton Peele, who I think was one of the first real revolutionary people to talk about the problems of diseasing people. And Diseasing of America was his book that changed my thinking, and looking outside of individualizing our problems and putting them as pathology in people, rather than the fact that we have societies and systems that often lead us to adapt and behave in certain kinds of ways. Some other people who've had an influence on my thought, Maya Solovitz. She's an incredible thinker and writer. I think you hosted her before on this podcast. Yeah, I mean there are more names than I can list, but yes, I didn't come here on my own.
Let me close with 2 short quotes of yours from the end of the book. The first is, "We should stop thinking about whether drugs are good or bad, or moral or immoral, and start considering the potential benefits and harms of drug policies." And then the other is, "We don't have bad drugs in this country, we just have bad policies." This is Sheila Vakharia concluding her book, The Harm Reduction Gap. I'm not sure whether I can hold it up to promote it, but that's what it takes to look that's what it looks like. And Sheila, thank you for coming on. Thank you for your wisdom, and thank you for writing the book. I encourage people to check it out. I've been through it twice now, and it's been very helpful and very informative.
Thank you. Thank you so much. That makes it all worth it.
Sheila and her book, The Harm Reduction Gap. Sheila, thank you very much.
Thank you.